healthcare business podcast from the Coker Group that focuses on solutions to help healthcare organizations effectively navigate the changing healthcare industry landscape.
Welcome back to another episode of Coffee with Coker. And today we're talking about physician compensation, but we're specifically following a series of pieces that we've done recently, talking about the changes that have been announced from CMS in regarding coding and starting in 2021, specifically changes to some E&M coding procedures and codes themselves. And we've talked about this from a couple of different perspectives, but as I said today, we wanted to cover how the whole issue of physician compensation could potentially change or be affected by some of these E&M coding changes. So with that, we want to dive right in, and we have joining us two veterans of Coffee with Coker podcast and a new guest. Justin Chamblee, who runs Coker's physician compensation team, is joining us, as well as Alex Kirkland, who has been on a podcast in the past and does a lot of work in the physician comp realm. Also joining us is a new member of the Coker team that we're really excited to announce. His name is Amit Vaishampayan, and Amit, we want to welcome you to the podcast. We're really excited about the different perspective and experience that you're bringing to the team already. With that, why don't we just jump right in, and I'll let whoever wants to jump in kind of kick us off the discussion, but just talk to us for a second about what are the kind of most noteworthy changes that we see in terms of the proposed rule related to the 2021 E&M coding and payment changes.
Well, Mark, when we were looking at the proposed changes, I think there were three noteworthy categories of changes. Number one is they're confirming the E&M coding changes that we've been hearing about for the past couple of years, as well as what those payment changes look like. And I'm sure we'll get into those details. And then they made some permanent telehealth changes in response to COVID, trying to make it easier for providers to bill and code those services. And then number three were updates to the quality payment program. Were also incorporated in within this. Again, another area I'm sure we'll get into the details of.
That breaks it down good. And so let's maybe start off with the E&M coding and payment changes. What's the big kind of takeaway there for our listeners?
Well, we've been hearing for a while about these prospective E&M coding changes, and now they're coming into existence starting on January 1st. And so this is seeing a large RVU increase for those E&M codes as they try to right size and eliminate the level one codes as well. And so that's going to have a big impact for the physicians that are doing a lot of E&M visits, those specialties that are driving those E&Ms. They're going to see an increase related to their compensation because it's going to have that large work RVU impact. So if they're on a work RVU plan, they're going to enjoy that change that's made. But in order to fund this E&M increase, they've got to keep the overall healthcare expenditures kind of level. And so they're having to implement the statutory budget neutrality mandate to do that. And so we are going to see a reduction of the overall conversion factor by over 10%. And so it's reducing from over $36 down to $32.60 for the overall conversion factor. So then those specialties that are not seeing a lot of E&M codes, they may be feeling the pains of this change. And this is really going to be based on if those specialties are part of groups that lock in rates. And so those rates have been locked in. They're then tied to their economics are really not aligned with reimbursement methodologies. And so that's where you're going to feel some of this disruption for this on the physician comp side.
Yeah. So 10%, that's interesting. It sounds like you're pushing well over $3.50, pushing $4 as far as the impact. Is that kind of change pretty consistent with what we've seen in the past?
This is a really large change that we're seeing both in work RVUs and for payment changes. And so in the past, that conversion factor has stayed very, very flat. It's been very consistent. And one of the things that we always talk to groups about, we try to illustrate if you're just relying on market survey data, it'll look like there's this perpetual increase. For what the surveys, there's always an increase in that comp per work RVU rate, despite the fact that Medicare CMS conversion factor has stayed so flat over the past, many years. And so another indicator that the survey can absolutely be detached from your economic picture. So that's something to be aware of. And then groups would need to be looking at how their rates are put together on their compensation plan. Is it something that they're locked into, or do they have the flexibility to make those changes on an annual basis?
And what you've seen thus far, as far as the proposed rule and what's outlined in these changes, is do you think the impact will be kind of equal across the board for all providers? Is there anything as far as certain specialties being affected, one more so than another?
Mark, I'll chime in on that and also make one note, sort of connecting the current dynamics to history. And if you go back literally 11 or 12 years, which shows maybe I've been doing this a little too long now, but in 2008, this was the last time we saw a dramatic change in work RVU values, similar to what we're seeing now. And what was interesting is at the time that the same dynamics were in play, wherein you've got the Budget Neutrality Act. And so even though the work RVUs go up, overall Medicare has to stay budget neutral. Thus, at the time, there was a budget neutrality work adjustment that was put in place that specifically addressed and adjusted down the work RVU value. So it was this sort of like give and take. Hey, we add more value to the work RVUs, yet we take it away in terms of dollars, such that it offsets some of the increase. And later they decided, no, we're just going to push that into the conversion factor. And so fast forward to today, we have the large increase in work RVUs, yet we're automatically addressing the conversion factor to bring it down, to bring the overall Medicare spend into alignment. And so it is still very much a give and take, giving to some and taking from others. And so if you think about the impact this may have on a per specialty basis, I think the winners will by far be those specialties that are hitting work or E&M codes the most. And the quote losers, the ones who are going to see the biggest financial hit, are those who are more specialty based or procedure based, who are largely charging specialty codes that are not seeing a work RVU change, yet will be subject to the reduction in the conversion factor. And so I guess just to summarize, number one, we've seen a similar dynamic of as this before, but you have to truly go back 11 or 12 years, and there truly will be winners and losers in this.
So likely those surgical specialties could be the ones hit the hardest from a loser or negative impact standpoint.
I would expect that to be the case.
Yeah, and that's supported by some data that CMS put together too. In the proposed rule, there's a table that they have in there. It's table 90, where they put together some projections based on different specialties, and it shows those surgical specialties expecting to experience a negative impact, whereas family practice and other specialties that have high E&M volumes, they're projected to see that give and take that Justin was just speaking to.
Yeah, that makes sense. So, Alex, what do you think kind of the overall comp implication is here with these changes?
I think groups are going to have to, be looking at their composition of services and specialties and trying to understand, what impacts this may have to different facets of their organization, and to prepare their physicians accordingly. So much of compensation is change management and helping physicians understand the why behind they're seeing things the way that they're seeing it. So I think that's a big action point that administration of these groups can take now.
What about, Amit, I'd love for you to jump in here, but how does this impact kind of the valuation perspective, or what's the implication there on valuations?
Happy to speak to that, Mark. Thanks for having me on here. I think it's noteworthy. It gets a little bit to what Justin and Alex were referring to, but essentially this conversion factor has been flat for 10 years. And so what that has done is the appraisal community has come to rely heavily on the survey data, because really the survey data it's generally reflecting kind of data from the previous year or two, and there haven't been material changes, at least like what we're seeing with this updated physician fee schedule. So this whole notion that existed for a very long time about, historical data being a good predictor of the future, when you're looking at the relationship between compensation, productivity, collections, that's just not going to hold up as true as it did before. Really, what we're observing is the compensation and how physicians are compensated is becoming, to some degree, unhitched when you think about the survey data from this year, to what it will be. And so when hospitals, administrators reference that and they go to pay their physicians, right, they're making it so that their top line minus expenses equals a bottom line. That equation is going to be a little bit wonky and create some challenges.
Yeah, that makes sense. What about talking about some of those differences between the primary care versus the specialty physicians, such as surgical specialties and things like that? Any kind of implication there that you anticipate?
Well, I think it's going to be really interesting. So the way that compensation plans are structured, it varies across the board based on a variety of different factors, but there's kind of the traditional eat what you kill model, where you are, paid per unit or per patient or per widget, so to speak. And then a lot of specialties essentially have a high base salary and then are compensated on hitting some kind of bonus thresholds for productivity. So what we might see is, again, getting back to what Justin and Alex might have mentioned, primary care physicians who are in that eat what you kill model will obviously see reimbursement rising. At least their employers will see that reimbursement rise. What I'm getting at is that the compensation may actually rise faster. And so many times, and this is, I think, common across the board, you've got certain specialties that are subsidized by their hospitals and by their health systems. And as a result of this, if you've got more RVUs in the mix, those subsidies might actually increase because the compensation and how it's adjudicated is administered or tied to a number from a survey where this equation made more sense, where the economics were stable. Now, all of a sudden, you've got a very different equation. You've got these providers being more, doing the same body of work, for example, but perhaps getting paid for more RVUs because of how they're cut up based on what we've been talking about. And so that's going to create real challenges for hospitals and health systems.
Yeah, absolutely. As we come full circle here on the impact from the E&M coding changes, one of the things that I think we've seen in the past is it's kind of just accepted. Okay, CMS releases their proposed rules, their changes to the fee schedule, et cetera, and good, bad, or indifferent, it's just kind of accepted. This is going to start January 1 of 2021. We've been talking about E&M coding changes and preparing for them. So as a related to coding practices and coding audits. But as we think about the implication on comp here, is there anything that groups or hospitals that employ or have own groups can be doing today, and as we record this, August, almost September of 2020, to start preparing for those changes and the impact there, to start planning for them, to make any changes that may absorb some of the negative impact and take potential opportunity from the positives from these changes? Anything there that you guys would recommend to start thinking about today?
Let me jump in here, Mark, real quick. There's like two consequences, at least that come top of mind. One of them is that if physicians are going to be earning more money, right? Certain physicians, they will certainly be hitting. So the review thresholds that organizations have in place right now, those may need to be reset because you're going to have certain physicians that far exceed those thresholds. They may not necessarily be relevant anymore, and others are going to really fall far below those review thresholds. And so I think it would be prudent for organizations to really go back and rethink, use this opportunity to rethink and reevaluate their general compliance governance framework, right? To make sure that it's not so rigid that it creates undue burden for those organizations to really look at all of these different arrangements. And what that's going to require is to really think about risk stratification and think about what are the implications of these changes on how organizations think about riskiness and how they manage this never-ending tug of war between business risk, right, making sure that you're compensating the physicians and entering into prudent arrangements, but also not putting yourself, in a bad place from a compliance perspective. The other twist to that is really commercial reasonableness. And so we've heard time and time again that regulators are really, when you get down into the cases, into the details of the cases and the regulatory actions, they're looking for the story behind entering into these arrangements. They want to make sure that there were appropriate checks and balances. This wasn't a story of bad, this wasn't a story of bad characters. It was just bad, it was bad facts. It was not having the right checks and balances in place. So I think those are two things that will be very important for organizations to focus on, especially in the near term.
Yeah, I have to think, we spend so much time, attention, and effort on the survey data, but kind of going beyond that and to tell that story is going to be critical here. And that's where I got to think documentation comes up and other steps. Any other thoughts there?
Yeah, and we've helped groups try to plan for this. Amit was just talking about the business risk and making sure that that's documented. That starts with trying to get a handle on what your forecast looks like. And so that's one way that we've helped a lot of groups is we've tried to, get their data in, run that through our proprietary tools where we can come up with forecasts and impact scenarios. And then that goes into, okay, what is the communication strategy? How are we going to make the broader physician base aware of this? And so there's a trickle down effect where, there's an analysis that starts, but then how do we communicate this and make everyone aware that this is happening? All things that we've tried to reach out and support groups through that transition planning type scenario.
Yeah. And I was going to just say the same thing. I mean, I think I would much rather be proactively doing modeling with respect to my current medical group and how this may affect compensation, may affect our prospective losses, all of those things now, and prospectively make any changes that are needed to make sure that the comp arrangements make sense going into 2021 versus as part of my Q1 true up. Step back and say, hey, I don't understand the results that are coming out of these equations. Why are the physicians seeing this massive uptick in work RVUs and comp, but yet, potentially, as Amit alluded to, our losses are growing. I would much rather be proactive now than have to be in reactive mode at that point, because I think good education and planning will resonate with physicians as opposed to having them experience something and then having to pivot to potentially make adjustments after the fact.
And that goes into the administrators of these groups or practices. They've got to tell that story. Why is this happening the way that it is? And survey data can only take you so far, and it's not caught up to what we're expecting to see yet. And so what we try to do is use survey data as a starting point. But then how do we apply some of that operational insight? What is the specific nuance to your situation that needs to be adjusted and help tell that story to prepare the appropriate stakeholders for what's expected to come?
Yeah, great points. I think those make sense. And continuing the discussion and moving to the second category, Alex, that you had outlined, we've talked a lot, particularly since the rise of COVID and the fallout from that we've seen thus far, about telehealth. And, we've conducted our own market study on this. We have talked about the changes as far as the proposed rule starting in 21. But let's dig into that again here briefly. And address or maybe just outline what are the key takeaways from the changes as related to telehealth, specifically in response to COVID, but permanent telehealth changes in the proposed rule?
Sure. Well, number one, there's a category 1 and category 2 type of codes that they look at as it relates to the telehealth code. Category 1 are deemed to be similar to other approved codes, and then category 2, they require specific analysis to understand what the potential clinical benefit is. Medicare has proposed to permanently place some codes that were created in that category 1 basis and to continue some of the evaluation in category 2. They're proposing to add a third category, which would allow them to test some new services in the telehealth space, like for rest home codes, emergency department visits, telehealth related there, nursing home, telehealth related visits. Those are things that are going to be looked at and evaluated. And I think this kind of just goes into the fact that CMS and these regulatory bodies are recognizing that this is a new and accepted way of receiving care. And we're seeing this reinforced by other market data surveys, where I saw one that said that up to 50% of patients said they would leave their current doctor for a better digital consumer experience. Well, I think CMS is understanding that. And so they're trying to have pathways for reimbursement for providers that are administering and providing these telehealth services.
So this seems kind of overall pretty positive. Wouldn't you agree, as far as expanding the access via telehealth?
Yeah, I think so. And, from the pandemic, there were so many groups that just stood up telehealth overnight so that they could continue to see their patients and, at a time when they weren't coming into the office. I think this is really just the watershed moment where we're going to recognize there's new ways of delivering care. And this is going to be one of those pathways. And so CMS recognizes the need to reward providers for doing that. And so they're going to permanently make some of these codes so that they can get reimbursed for it. So yeah, I think this is all a good thing and a sign that they'll continue to evolve reimbursement rules that align with how care is being delivered. And one of the things that we saw was they're going to discontinue this audio only telehealth services. And so they're going to require a two-way video and audio communication to be required for reimbursement. So I think, again, this kind of goes back into the fact that patients are looking for that digital experience. They feel like they can get a similar, if not the same type of experience from the comfort of their own home. And as a result, CMS is trying to keep up with those consumer trends.
And again, I think there's a lot there. Seems to be that there's going to continue to be more kind of embracing from CMS of telehealth as it continues to evolve and be defined a little bit more specifically. Coker has really been covering the overall telehealth discussion, particularly throughout the last 5 or so months. In fact, we just had a piece recently, and we'll make sure it's linked in the notes for this episode. But talking about the impact on valuation as a result of telehealth in general, but specifically these changes as far as access for reimbursement via telehealth. So I would encourage folks to review that because it's gonna impact groups and providers, hospitals, in a variety of ways. I think at the end of the day, it will be overall positive, but we're still like you said, Alex. A lot of folks adopted telehealth very much overnight in response to the COVID increase or expansion. So that's going to be something that we continue to see revised and updated. And then I want to jump though to your third category you talked about was how the proposed rule addresses some changes to quality-based initiatives and quality programs. You want to give us a highlight there of the key points? Yeah,
and I think that we're seeing within the ACO world some scoring and policy changes to acknowledge that providers will not immediately recover from COVID overnight. we saw that earlier this year where they're trying to identify COVID-related diagnoses and to try to carve that out of the benchmark. I think there's more of that CMS and by extension lawmakers, they have spent so much time and effort into these value-based models over the past 10 plus years that they want to see them succeed. That is in their minds how we're going to bend the cost curve and reduce healthcare expenditures beneath 18 to 20% of GDP. And so the way that we're going to get there is by having these successful population health type payment structures. And so I think that we're seeing through this rule and what we saw earlier in the year, a commitment from CMS to keep these value-based reimbursement structures viable, and so that providers can benefit from them. But at the same time, the providers have to be able to move and adapt within them. And one of the things that the proposed rule does is it shifts category weightings within MIPS so that next year we will, in 21, the quality weight will be reduced by 5% so that more of the weight can go towards cost or resource use. And so we'll see quality make up 40% of MIPS scores and cost make up now up to 20%. Again, it's going to continue to increase over the years. But this is the real way where even if you're not, quote unquote, in one of these, what you would typically consider a value-based reimbursement model, by virtue of being in MIPS and having Medicare patients, you have reimbursement that's subject to some of these value-based principles. And you're going to be responsible for the total cost of care, whether that's delivered by your group or not. If it's attributed to your group, you're going to be responsible in some regard. So groups will continue to have to think about how they implement these quality and value-based care component structures within their compensation structure.
Yeah, I'm curious, what's kind of the key implication there when you think about the shifts and the weightings there between quality and cost? What are the key implications in your mind?
We're seeing more and more support for managing costs, and that's ultimately where we're trying to get to. This is still a new concept for a lot of providers, and so we're still seeing the ramp up where more of your reimbursement is subject to that. And I think that the private doctors will recognize that sooner than the employed ones, because they actually take on compensation risk, where if you're in an employed environment, depending on your comp model, but mostly you take on compensation risk, not revenue risk. I misspoke a moment ago. In the private space, it's revenue risk that they have to take on directly. And as more and more of that revenue risk is associated with cost management, it's going to promote the attention of physicians. And so to the extent that you can align your comp plan, if you are in an employed situation or not, but you just want to make sure that your comp plan is aligned to the manner in which you're being reimbursed, you're going to have to incorporate some element of that thinking. A way that we help groups is trying to be more progressive with panel management. Making sure that it makes up those themes, those value-based principles make up the right amount of their revenue mix. Then is it appropriate to have some panel metrics brought into their compensation plan? And so that's one way that we try to help groups through this.
Yeah, so I'll ask the same question I did previously, but and Justin, I know you and Alex and Amit all spend a lot of your time working with our clients, particularly hospital health system clients that own groups and employ physicians on comp strategy and specifically designing models, new models, or updating older models, whatever it may be. So my question earlier, talking about what can they be doing today, what can they be thinking about working on today in order to prepare for some of these things, is that you think the whole comp strategy and comp design perspective applies here?
Yeah, Mark, I think it's a great question. And one of the things that we've really worked on with clients is to develop a comp strategy or comp structure that is flexible and malleable as the industry changes. And I think the dynamics in this proposed rule highlight the necessity of that, meaning you've got economic changes by nature of the work RVU values changing, as well as the conversion factor changes. I think you also have what I would call some structural changes with respect to how QBP and other value-based arrangements are changing. And so in short, yes, I think health systems need to be looking at their comp structures right now and saying, specifically focused on what the proposed rule is calling for, are we prepared? But I think bigger picture, I would be suggesting they ask the question of, if this is an indication of what's ahead, meaning ongoing changes, do we have a comp structure that can accommodate those changes and mold and adjust as the industry adjusts? Or every single time something changes in the industry, are we going to have to go back to the drawing board and recraft our current comp structure? And I think with the highly dynamic environment that we're in right now, that is not a functional environment to be in, meaning this hard and fast, unchangeable comp structure is going to leave you wanting something more. And so that's one of the key things that we have been working with clients on, is to say, can we develop a comp structure that is more adaptive to what's going on? And I think that's one of the key things that I would suggest large medical groups to be looking at is number one, very specifically, what do we need to do about these changes? But big picture, what can we be doing to be able to easily adapt to any change that's coming down the pike?
Yeah. And just to further that, we get a lot of requests for groups asking us, how can we incorporate a value-based component structure? And naturally, we help out and enjoy that work of doing so, of thinking how that fits within their existing structure. But sometimes that does result in complete redesign. And the groups that can have that incorporated in some way, have a leg up. If you're thinking about compensation, it's so much easier to go through a tweak than a whole scale redesign effort. And so again, that just speaks to what Justin was just saying, that when we help a group design a comp plan proactively, we're thinking about how can we have a value-based component within that structure, so that you can adjust a percentage, you can make a tweak, you can do something as your economics change, but so that you have the structure in place and you don't have to find yourself in a few years trying to figure out a way to embed that.
Absolutely. That makes sense. This has been extremely helpful. And of course, we've kind of only raised the surface as far as everything in the proposed rule that we're anticipating for next year. Anything, final points did we miss anything, or other key takeaways?
I think we've captured it well, Mark. I think the key thing I would say is we see physician compensation as a living and breathing organism, both from a strategy standpoint, evaluation standpoint, and I think the market that we're in calls for that. And so I would just encourage clients to view it in the same light, because if it is viewed as a constant or a stagnant, I think things are going to change such that they may be behind the eight ball.
Absolutely. Well, again, I appreciate you all giving us the rundown here of what we're anticipating. And again, I just want to encourage everybody that, we're going to continue to monitor this and dig into the specific ways that the proposed rule and these changes could potentially impact our clients. And that's something we're watching very closely, and we'll continue to have information and materials out there to help navigate that process and prepare and plan for it. So I guess that's just me saying everyone should definitely stay tuned, because we'll be continuing to have this discussion as we learn more. But in the meantime, thank you all, and we'll look forward to continuing the discussion in the future.
Thanks, Mark.
Thanks, Mark.
We hope you enjoyed that episode of Coffee with Coker, and we thank you for listening. We want to encourage all of our listeners to participate and contribute in the podcast. So if you have any questions on any of the things we discussed in this episode, any of the topics that were presented, please feel free to ask us. Also, we welcome your feedback and suggestions. If you have any ideas related to the material we discussed in this episode, or in any episode, please let us know and we'll make sure to incorporate it. And if you have ideas for topics you'd like to hear more information about in future episodes, please send those suggestions to us. We would love to hear them and we'd love to incorporate them into our future episodes. You can find us online and on social media. Start with our website, and specifically the podcast is coffeewithcoker.com. You can also find that through the main Coker website at cokergroup.com. You can also find us on social media, Twitter at Coker Group, and then on LinkedIn, you can search for Coker Group and find our page and the page for some of our team members as well there. So you can find us and reach out to us a number of places. And then if you want to contact us directly, one of the best ways to do that, email feedback@cokergroup.com. That's feedback@cokergroup.com. And again, we'd love to get your feedback, and we'd love to encourage everyone to subscribe to the podcast so that you can be notified when future episodes are released. We look forward to the next episode, and we look forward to getting your suggestions and feedback on this episode. Thanks for listening, and we look forward to speaking with you again on future episodes.